Here. Now, it involves these four parts of the body. You can read that. I'm not going to read my slides, but I am going to read my my questions here. So why? What do these seemingly disparate parts of one's body have in common? You guys got to speak up. My hearing aids are on, but they're not as good as my voice.
Outer portions of the body, closer to outside.
Exactly, they're external. They are close to the surface of the, and so let me challenge you one step further. Why would that be the case? What do you think would be the reason for that?
The reason for it to affect
To attack
parts versus
the nose, anterior portion, only the anterior part of the eye, the skin, and the superficial peripheral nerves.
It's a temperature thing as far as
Exactly,
bacteria.
all right. Perfectly. Now, did you know that or did you deduce it?
No, I knew that.
All right, so what's the temperature? I'm gonna really nail you here. What's the, what? No, that's not, we're not here to, no. Okay, but the fact is that M. leprae grows best not at 98.6 degrees, but at 82 degrees Fahrenheit, 28 Celsius. And if you know that, plus a couple of other facts here, maybe you actually read the handout, that would make a difference. That will predict this. So here's the three facts that, I'm not a basic scientist, but there are a few factoids that actually, in many diseases, if you remember them, they will help you to be a better clinician because you can organize it around some of the scientific underlying, in this case, of the bacillus. So it's, this is the main thing. It's also lipotrophic or at least neurotrophic. And finally, and almost as important, is that it is a very slow reproduction time. So if you have a staphylococcal infection or any other typical bacterial infection, you're going to double your number of bacilli every 12 to 24 hours. And here it's 12 to 24 or 21 days. So the corollary, not necessarily, I can't prove why it's true, but the fact is that this also is correlated with a very long incubation time of anywhere from 2 to 20 years. So you're talking about hours and then days, and then finally between the time you become infected with M. leprae and the disease, it's an average of 5 to 8, but a range of about 2 to 20 years. So it's a very slow growing guy. Okay. Well, so is this clear enough, or should we cut off some of the lights in the front? It might be better, because you can't really see the lesions here. Okay, that's a gamble that you're going to stay awake. Let me see what this is. Okay, so the other aspect of this projection is that it flattens out because this is a wide screen. But anyway, so this woman obviously has a very large plaque. She's got a number of other ones there. She has some lesions on her face. So skin nerves, this is the posterior auricular nerve, which obviously, as you all remember, comes from the third spinal level and is deep to that, doesn't enlarge. The minute it emerges from the posterior border of the sternocleidomastoid, it may, because it's now cool, that part of it may enlarge and be as obvious as this. Here's the first CAN slide that we've been lucky enough not to have too many eye problems in Arizona from leprosy. So this is from the National Hansen's Disease Program, and this is iritis, which you wouldn't be able to tell from any of the other protean causes of iritis, except that you know this patient has leprosy, you know that they're lepromatous, and you know that they're in a type 2 reaction, which you'll be able to explain to me by the end of this talk. And therefore that this classical case of iritis is in fact due to leprosy. And it's among the top 8 or 10 still leading causes of blindness in the world, leprosy. Okay, so again, the HEENT, mucous membranes is probably the portal of entry in nearly all cases, and because it's cool, it's also the place of initial multiplication. And sometimes this progresses, as it has here, and then a couple of other patients in the US, to septal perforation. And so people with this, when it does progress, get the flat saddle nose that sometimes you see in the stereotypical photos of leprosy. This woman, actually, I saw when I was practicing in Papua New Guinea, and she didn't complain about her nose. She complained about, her chief complaint was, doctor, when I take a drink of water, it comes out through my nose. So this had perforated not only her nasal septum, but her hard palate, which is a classical but rare manifestation. Okay, so this translates at sort of the next level, the next sort of clinical level, to the kind of things that you should be looking for clinically. I think that's about perfect now. So an anesthetic skin lesion, you've probably heard this, is leprosy until proven otherwise. But that's a pretty poor rule in this country because there's plenty of reasons to have anesthetic skin. What if you've had an operation like I did here and your nerves are cut? What if you have a dense scar? There's plenty of other reasons. So you need to have more suspicion than that, and that suspicion largely comes from the fact that epidemiologically they've almost always lived in an endemic area for some time, if not born there. Enlarged peripheral nerves, again, that's pretty rare except for leprosy. Clearly the neuropathy in many ways resembles diabetes, but the nerves in diabetes are neither enlarged and rarely tender. The closest you get to pathognomonic is the fact that the organism can be seen as an acid-fast bacillus, looks just about like the TB bacillus and can be stained with similar acid-fast stains, can't be grown on any known artificial culture media, so that's a bit different. We're going to talk again about where you would look for this and where you might only see that. So in this country, the skin biopsy is almost always the way that the diagnosis is made, and often inadvertently. So you go to some doc, it may be the rheumatologist because you got funny looking hands, or it may be the neurologist because you got a funny numbness. And sooner or later, if they get to the dermatologist, and they don't know, then often they do, and the dermatologists are the most likely persons to know about this disease in this country, but the dermatologists, whether they know or not, will do what dermatologists do, which is a skin biopsy. And if it's sent to the right pathologist, and which is most, with the suspicion of leprosy labeled, then it will generally be picked up, but not unless they do the special stains. So this is the sort of clinical summary that we'll now try to elaborate on. So there it is, within a nerve. So can you get leprosy from an armadillo? Only two answers, so. Yes? No?
No.
No, of course not. Well, yes, you can. This was suspected for some time because in the US, virtually all of our cases come from immigrants or those who have lived abroad or contacts of recent arrivals from endemic countries. But there have been, since the early days of the leprosy program in Louisiana, cases that didn't meet this description and in fact had no known contact with any case and had never been outside of, in some cases, one county in the South. But the distribution of endemic leprosy in this country is coterminous with the distribution of the 9-banded armadillo. So the correlation doesn't prove causation, and so there was all kinds of speculation until this article came out, the New England Journal, and I mentioned the genome has been sequenced. So using some smart genomic techniques, which I couldn't either explain or understand, my boss, David Schollard, and his colleagues proved that in one patient, that the genomic sequence was identical to the ones that they were getting out of armadillos, and so to the people that look at that, that's the first proof. There have been plenty of other cases about armadillos that have been under the house, and the owners had dug them out, and they all got scratched, and they carried on, and so but this is the first, at least molecular level proof. So is that proof that that armadillos gave armadillos are an endemic zoonotic source, naturally? Well, I asked these folks, and because they didn't address this in this paper. So where did the armadillos get it? Maybe it was from the colonialists, maybe from Columbus's people who had leprosy, and now they're just giving it back to us. I don't know. So there's still a few questions, but I digress. But anyway, this is the totem animal for leprologists.
Now it's also in the chimpanzees, right? Chimpanzees can also harbor the organism.
Well, they can be infected artificially, but they don't have it endemically or zoonotically. Yeah. And you can inoculate it into the foot pads of mice, and it'll grow, but it won't transmit. So these are things we're going to skip over because I've reviewed them. So getting back to the worldwide picture, the countries that you would expect tropical diseases to be in is where leprosy is, but who was Armauer Hansen of Hansen's disease? The sort of pseudonym, politically correct name for leprosy. It was a Norwegian who discovered this in Norway in 1873 in Norwegian leprosy patients. So it's got nothing directly to do with being tropical. But this is where it is. And so Brazil and India have the highest number of cases. Currently, the rates are here. The World Health Organization is fond of saying that the leprosy problem is almost licked because they define the elimination of leprosy as a public health problem as less than 1 per 10,000 population. I don't have time to go into the arguments made by the classical vertical leprologist that is probably an artificially contrived number based on different ways of counting it. The point is that nobody disagrees that leprosy is markedly, if not dramatically, decreasing in the world, even while TB is kind of barely being dented given the AIDS epidemic. These are two closely related mycobacteria, so why would you not expect in places where AIDS is rampant to have leprosy rise in prevalence just as tuberculosis has in those countries? Well, that was another mystery, but it hasn't. And there's a whole discussion around that. So prevalence can be based in highly endemic areas by case finding, and this is a gentleman from our program in New Guinea palpating for the ulnar nerve and looking at plenty of skin. And these are the nerves, just as you would expect, that are superficial and therefore involved. And when you come to the limb nerves, the ones on the head are probably of no great clinical consequence, but if you think about the major branches of the sciatic and all three branches of the brachial plexus, these can be extremely debilitating if they're involved in their motor aspect. If you understand this slide, which I don't think is too complicated, then you've got everything you need to know, and we can take questions. The fascinating clinical as well as some public health aspects of leprosy is the interaction between the organism and the immune system. So it's been estimated that probably not more than 5% or so of people who are exposed to leprosy will actually get it. So most of us have some sort of innate immunity. Then for those who do get it, the degree of very specific cell-mediated immunity to this organism determines where they'll be along this spectrum. And this has nothing to do with general CMI lack like it does in AIDS, where you can predict exactly what's going to happen. This has no correlation with the CD4 count. It has to do more with the specific cell-mediated immunity. And at this end of the spectrum, the tuberculoid end, the immunity is exceptionally good, which means that the inflammatory response is exceptionally high or bad if this is in a nerve and the nerve gets inflamed from the cell-mediated immune response. And so I'm not sure whether it'd be better to be on this end or this end, because this end you can damage your nerves, particularly right about here on the spectrum. So here there are few germs because they've mostly been controlled, but the immune response is the cause of the problem. At the opposite end, there's virtually no immune response, and you have billions of bacilli invading all of the peripheral areas, and some of the reactions are caused by the immune complexes of the organisms. In the middle is where many patients present, and they may go in either direction. You rarely stay mid-borderline for your whole life. This is an unstable state, so the inverse correlation between CMI and bacillary load is about all you need to know. These 5 categories were proposed and are still used since 1966 by Ridley and Jopling. This is something you can read in the reading that you have, and it's a much more busy slide showing what you would expect to see in terms of skin and nerve lesions. The vertical line here is important. We'll come back to that as well. in the treatment, particularly the WHO standard treatments. So they're the tuberculoid and borderline tuberculoid are considered postbacillary by sort of definition. They have few bacilli and therefore require fewer drugs in a shorter period of treatment than do the multibacillary, which, as I said, can have billions. So this is as important in public health, if not more, than exactly where the patient might be in the 5 categories. So I'm going to take you through from this end to that end, from the tuberculoid to the lepromatous, again hoping that this helps us to recognize what some of these patients will present with. The slides that are not my own are from the renowned Stanley Brown. And this is the first from him. So he's showing you some early lesions of tuberculoid leprosy. This might not even be anesthetic because if it's on the face, because the face is replete with sensory nerves, and so despite the dictum that an anesthetic lesion is tuberculoid leprosy, early it may not be, but that's the exception. And here, these will almost certainly be anesthetic. If they're not, it's probably not leprosy. Here's then one of our patients from Arizona, hypopigmentation, no motor loss, and that was the saving grace here. So his skin looked funny, but he did very well. On the other hand, here's a gentleman with exactly the same type of leprosy, tuberculoid, borderline tuberculoid, who had, as you can see, bilateral ulnar nerve damage. He's got thenar wasting from the lack of the median nerve, and he's got clawing, that's mainly ulnar. The only nerve that's not involved here is the radial. And being a cowboy, he's got rope burns on his left hand from holding that rope. And these lesions are, of course, not due to leprosy, but to due to secondary infection from the insensitivity. Here's a woman that was from our border town of Nogales. She's literally walking on the end of her tibia. This is a Charcot joint, not that dissimilar from those in diabetes or in the old days of tabes dorsalis of Louis' tertiary syphilis. This is her radiograph. I didn't capture exactly the worst part of it, but literally she is walking on the end of her tibia. So here's borderline, the middle of the spectrum, and it is literally a fight between immunity and the bacillus, so you've got a lot more lesions, but they tend to heal from the center, just like ringworm. So the differential here is typically tinea, but because the center will forever remain anesthetic, it should not be mistaken, especially again if they have endemic demography. Here's now one of our patients from Somalia, densely anesthetic. Notice that they're not in the midline. That's fairly typical. Well, you got a little Dutch oven there. It's a little bit warmer. Not always true, but fairly often. Well, where did he come from? Well, he came from Kakuma. Should on the bottom, I've never been there, so can slide, although I've been in Kenya. And I know with Dr. Khan's interest that you're probably hearing more about the other big camp there, which is near the Somali border, where polio probably was imported from, and who knows, maybe the shooters at the Westland Mall in Nairobi as well. So this is currently in the news. Back to Arizona with a really hard-working gentleman frying up his chorizo one morning. half asleep, like I am when I wake up, and he's resting his hand, I guess, too close to his frying pan, and he looks at it, and lo and behold, it's down to the bone. You could take this arc, create a radius, and calculate the size of his frying pan if you wish. Totally anesthetic. But his skin wasn't very bad, so here's a couple of typical borderline lesions. Now moving on to lepromatous, here's Stanley's introduction to that. So many AFB that you don't get it in patches, you get it all over, with occasionally some accentuation in some areas, which may be harder to detect. They may be less, typically, or less anesthetic. May look like just about anything. This could look like secondary syphilis or any number of things. The other aspect here that's shown is that in leprosy in general, the lesions in lighter skinned people become darker than the surrounding skin, and in darker skinned people they become lighter. Here's one of our long-standing patients in Tucson. No eyebrows, no eyelashes, saddle nose, septal perforation. Another even more unfortunate gentleman who did have some eye involvement. So you don't need to go to developing country to see this disease, but this is frankly the worst I've seen anywhere in the world. And how he wasn't detected, I don't know, but this is the way he came to us. Incidentally, he also had coccidioidomycosis, or Southwest disease, and had lumbar lesions in the bone from that, so it was a pretty sad gentleman. On the other hand, here's another patient who also, like the previous two, has septal perforation. But it's not so bad, barely detectable. In fact, maybe even a mark of beauty to have this little nasal contour. She was extremely ill when we first saw her and weighed 77 pounds, but responded extremely well to treatment. Here's a typical case that you will see, not a new case, not hard to diagnose, but these are folks that tend to stick around hospitals because they have enough disabilities, and this gentleman was in the Presbyterian Hospital in Chikoria, Kenya. I actually do not know at this stage whether he was lepromatous or tuberculoid. We could debate whether you could tell, and maybe you could. But so here you see the extreme results of two things. Now, we tend to think that this is all caused by leprosy. Well, it is, but is it caused by secondary infection because you don't know you're being injured and you get cuts and turns into osteo, or is it due to the fact that you don't know your proprioception, you don't know your grip strength? It's probably both. I mean, it is both, for sure. Because some people have never had osteo and they have resorption. Some people have never have so much osteo that you can explain it that way. So it's really both. So the diagnosis, enlarged tender nerves, anesthesia, especially with filaments, which we'll look at. 6-site slit skin smears. We'll talk about that. Biopsy. There's no blood test that is of any use, nor is there a skin test. So here is what is familiar to every clinician in this country is the fact that you use this filament, the 10-gram filament, to test for diabetic neuropathy. It turns out, maybe you know this, that this whole concept of grading the degree of sensory loss by carefully calibrated filaments measured in dynes per square centimeter pressure came from the work of Dr. Paul Brand when he retired from India and went to Carville to do this research. Because it was under the Public Health Service, and because we all recognize that diabetes is such a major problem, it was determined that this 10-gram filament is the one that would differentiate protective sensation, or the loss of it, on the sole of the foot of a diabetic, or for that matter, somebody with leprosy. But we have a whole spectrum here, and we have that gentleman with the burned hand could not feel this one, even though it's hard to bend. These other ones are so fine that if you use a normal person and touch them on the back of their, between their shoulder blades where you have fewer sensory endings, you might not feel it. So because the sensory loss is progressive, we do our best to monitor that and make sure that there's no sudden loss, which we'll get to in a minute. The slit skin smear is a rather primitive seeming but very simple procedure, which literally is just that. You slit the skin 4 millimeters deep, 8 millimeters long, turn your blade sideways. You previously squeeze the earlobe to make sure it doesn't bleed, and the serum of the subcutaneous tissue, which will be loaded if you are positive with bacilli, is put on a smear. It's let dried and it's stained just like you would a TB stain, and it's highly quantifiable in the log scale. In fact, it is the best way of determining response to treatment, since we can't culture it. This is the log scale per high-powered oil immersion fields. Punch biopsy, which you're all familiar with. This slide, you don't need this slide, but the information is in the handout in the article. In fact, everything you need to know about leprosy in this country you can get from these folks. From how to send your specimen in, to whether this patient has leprosy or is in reaction, or if you need some of the drugs that are harder to get. So this is all you need to know. So, regimens. What do we treat it with? As I mentioned, you need less drug pressure on this end. So the drugs are the same, the regimens are different depending upon whether it's the WHO regimen or the American. Neither has been proven superior or inferior to the other. We just have more money and more rifampin. But for the low-load patients, the tuberculoid end, literally they can get two capsules of rifampin a month, 100 milligrams of dapsone daily for 6 months, and they will be cured. If they got problems with their nerves, if they've got deformities, I'm going to help a bit, but it will stop the infection. Multibacillary, twice as long, and an extra drug. What we do is give all of them daily, and we do it twice as long. So in our country, the way to remember this is 3 drugs for 2 years, or 2 drugs for 1 year. This is the standard treatment for WHO multibacillary cases. So they come in every month, they swallow their rifampin, they swallow a high dose of clofazimine, and then they take the dapsone for that day, and then they march along and take 150 milligram clofazimine and 100 milligrams of dapsone daily until the next time. So how do we monitor this? Again, there's no test except for the slit skin smears, but we keep watching them clinically. Sometimes we repeat the biopsy, but rarely. Well, reactions can be a complicated topic in itself, and sometimes I skip over this, but it's really important for two reasons. One is that many patients are not bothered by whatever's going on with their skin, or even the gradual numbness that comes to the nerves. But when they get sick from leprosy and they are in one of these two kinds of reactions, that's when they're likely to first show up. So that's when you may see them, and you should recognize that they have leprosy. More importantly is that this, at least the type 1 reaction, is the only emergency in leprosy. That is, if you don't pick this up and treat it within at least a few days, you will likely have irreparable nerve damage, and especially if that is in the motor nerves, it will be the end of that limb function. So this is in the people with good immune systems. It's in fact their immune system fighting back. It's a little bit like the IRIS in AIDS patients who are started on ARVs, especially if they're started with TB. So this is the treatment, the only treatment that we know of that works. Type 2 is a different kind of reaction. This is true delayed type hypersensitivity, a type 4 Coombs reaction. This type 2 is really a type 3 or an Arthus reaction, if you want to use the ACID mnemonic for the four currently recognized types of immune response. In fact, these were recognized before the leprosy reactions were named and recognized before we knew about all these other ones, so the numbers have persisted even though they don't describe them in modern terms. So here's a gentleman with a type 1 reaction, and he had all kinds of anesthetic skin lesions, but they didn't bother him. Now they got all lit up, and he's got swollen fingers, and he comes in, and that's when we first saw him. Here's another sad case for especially those of you that are baseball fans. So what do you see? Anything there? I think you can see it from there that while he's not bothered by this hypopigmented area, this is densely anesthetic due to the involvement of the supraorbital nerve right here. But if you're a baseball player and your hand gets swollen up and your orthopedic surgeon paid $400,000 a year by the Milwaukee Brewers to take care of you, thinks that this is some kind of tendonitis and operates on it when it's actually a type 1 leprosy reaction neglected for the 2 months that he was getting worse. He's already got a claw hand here. He's later got atrophy. Despite treatment, he was shipped back to the DR with no compensation. Here's the other kind of reaction, which is the ENL, or erythema nodosum, which is what it is, but when it's associated with leprosy, it's ENL, or erythema nodosum leprosum. And this is the immune complex disease. There's a lot of subcutaneous nodule swelling, usually fever, and rather severe, sometimes generalized illness, and this will land people in the hospital sometimes. It tends to be on the extensor surfaces of the forearms and the thighs. This is an evolved lesion, or several that have evolved in this same patient and are now somewhat atrophic. Well, reporting, this is an R that I didn't put in your outline, but this is the form that we send in. still on paper, actually, I don't know why, but this is a Marshallese patient who came from a household of 11, and he was lepromatous, and so he started on the 3 drugs, but we needed to monitor, is there secondary cases? Well, there were none, but we're more concerned about 3 or 5 years out now about these other 11 people. So this is the challenge, and much more challenging even than TB, given the long and unpredictable incubation period and the fact that we can't go out and do a skin test on these folks because they're in there. Well, we're moving along quite rapidly, I hope, now in the R, so rehabilitation. About 80% of our time in any clinic actually that deals with leprosy is not, at least in this country, new cases, it is trying to rehabilitate secondary, tertiary prevention of the people that have problems. And we have an excellent orthotist working with us, Ron Favors, and he's the shoe man, among other things. Ugly but good. So these are plastizote impressioned shoes. The resources, again, these will be in your resources, and so here's our main resource in this country. But there are leprosy associations around the world that are still NGOs, often started by churches, that still do a lot of work, and the WHO at least looks at the public health aspects. So this is your review. This is the last case. This is not my own, but it's from the National Hansen's files. So here's your test. What kind of leprosy does this gentleman have, and what does he, how would you find out for sure? Well, he's got his face involved, and that only happens in lepromatous leprosy. He's got tons of redundant skin loaded with billions of M. leprae, so he's got classical leprosy with the so-called leonine lion-like facies. So it's a disease that has been stigmatized since antiquity, and in our famous town southeast of Tucson, where I live, in 1882, 2 Chinese died of leprosy, had no name, and were buried in a common grave. I'll close with this. Have you met him? Thank you, yes. So it's very satisfying to treat this disease, and this gentleman certainly, although I never met him, represents the kind of rewards that come from working in the disease, which has so many clinical aspects, but is so vital that be treated from a public health standpoint with medication.
So is this 1 year later or 2 years later?
This is probably 3 or 4 or 5 years later. Yeah, I mean, he'll take 2 years of medicine, but it'll take a longer time. In fact, the AFB in your skin, they're fragmented, but you'll still see them. You'll see them 4 or 5 years later if you do a smear. But they're not viable and they're not replicating. So it takes a long time for the skin lesions to go away, even longer than the treatment duration. So that's it. Unless there's questions.
I had a question.
Sure.
BCG does work in maybe 20 to 40% of the population. A double dose of BCG, do you think that something like that should be tried, or should, because in the United States you're not supposed to get BCG, but
Right. Well,
BCG is given.
that's a good question, and it's not a plan, but that's one thing I didn't talk about. But probably as important in the decline of the numbers of leprosy cases in the world as treatment. Just as important is the fact that BCG is the most widely used vaccine in the world. And it has been shown to have reasonably good efficacy against leprosy. It's actually better against leprosy than it is against TB. Even though the justification for BCG, as you know, is to prevent the complications of childhood tuberculosis in the very first few months after infection. But in fact, hey, we'll take whatever we can get.
Yeah, and they say that double dose of BCG is even more effective.
There's never been any proof that a higher dose, it's a live vaccine, so it's going to multiply in your skin anyway. So there's no reason to give a higher dose, as far as we know. Yeah, it's a good question, yeah, back.
Do you ever get false positive tuberculosis skin tests if you have leprosy or you're checking for?
I'm afraid you got to really speak up.
Can you ever get false positive tuberculosis skin tests when patients have leprosy?
No. That's amazing, because you can have all kind of other environmental mycobacteria like M. kansasii and M. battii and all these other things, which will give you a certain amount of reaction to the tuberculin test, but this won't.
Yeah, you made a reference to a patient of Dr. Stanley Brown.
Mm-hmm.
He had come to this hospital to give a lecture in
Really?
the early 80s.
Uh-huh.
So I recall one statement he made that during his lifetime he had touched almost 20 to 30,000 leprosy patients,
Patients, right.
and he had yet to contact the disease, according to what he said. So his comment was basically that this is not such an infectious process if you are careful. So any comments on, does that statement still true?
I think it's all statistical. I mean, Stanley Brown, like myself, were medical missionaries in parts of our lives, and so we, I think we believe in providence, but in this case, I believe it's just plain old dumb luck. It's not that, so he's probably inherently resistant. He's one of those 95%. I probably am too. But you know the story of Father Damien in Hawaii, who lived in Molokai, the other leprosy hospital in this country, and contracted it and died there. But that's pretty rare.
So there's a difference between the WHO recommended treatment and what we do in the United States. Is there any data showing the relative efficacies of both, or are they about the same?
They're the same. We used to treat until 1990. We would treat for 3 years, and so finally, our bosses, who are still very conservative, and we've got enough rifampin to treat the world, I guess. So they compromised on what we're still using. The problem is if somebody goes off treatment, and that happens probably more here in this country than it does abroad, and misses treatment, are they going to more likely get resistant? Or conversely, if we give rifampin every day, which is highly bactericidal for leprosy as well as TB, maybe if they do go off treatment, we will have given them enough, even if we lose them to follow-up. So there's a number of rationales why we do that, but it's not because there's proven superior efficacy.
I feel like something I learned was that leprosy is most common in poverty. Do you know of any cases where that wasn't the case? Was it with someone who just was exposed, or they?
Oh, sure, yeah, it is, and it's probably, so who knows? It's probably an airborne infection, and so like TB, it's not that you're poor per se, it's that you're living indoors in a closed environment with 11 other people. That's probably the ultimate reason. But no, we've had like an Air Force colonel who served for just a year in Vietnam. He's got it. Unlucky, one of those 5%.
Well, thank you so much, Dr. Pust. I wanted to mention that the handout which was emailed to everyone, not everyone may have received it, so printouts have been provided to everyone here. And Dr. Pust is going to be at the AFP Global Health Workshop which starts tomorrow, goes through Saturday. And our program is going to be presenting there as well. Navneet Sahu, Rachel Barney, and myself will be presenting on behalf of the rest of the global health team. And as always, thank you very much, and thank you to our guests.
I meant to mention that if you do discover a leprosy patient